Why is an ICD not useful soon after myocardial infarction? A substudy of the defibrillation in acute myocardial infarction trial evaluated why an ICD is not useful soon after a myocardial infarction. DINAMIT study had randomized those with recent myocardial infarction after 6 to 40 days, left ventricular dysfunction, and a low heart rate variability to receive an ICD or just standard medical therapy involving 653 patients. It was a negative study in that ICD therapy failed to improve survival. The substudy concluded that ICDs do not reduce all-cause mortality in those with a recent myocardial infarction. This was because those who get an arrhythmic death averted by an ICD have a high ischemic burden and heart failure risk. This leads to a higher mortality in the subsequent weeks or months. On the other hand, the lower risk group have less chance of ICD shocks as well as subsequent mortality. There was also a higher proportion of ventricular fibrillation of 38% rather than ventricular tachycardia among the causes for appropriate ICD discharges compared to other primary prevention trials. This may also be a marker of higher mortality risk. The study was not able to identify whether the arrhythmia needing the ICD shock caused deterioration of cardiac function or an additional factor caused both together. It could also not show whether the shock itself directly or indirectly led to higher mortality. This was because the small number of deaths in subgroups limited the role of any such analysis. This study also highlights the fact that ICD therapy may not always mean averting a death. A competing risks analysis showed that those factors which increase the risk of arrhythmic death also increase the risk of non-arrhythmic deaths. Reduction in sudden cardiac death by the implantable defibrillator was fully offset by an increase in non-arrhythmic deaths, which were greatest in patients receiving defibrillator shocks. The IRIS study also showed that prophylactic ICD therapy did not reduce overall mortality among patients with acute myocardial infarction and clinical high-risk features. The study enrolled 898 patients 5 to 31 days after myocardial infarction if they had left ventricular ejection fraction 40% or less and heart rate 90 beats or more on first available ECG and or non-sustained ventricular tachycardia at 150 beats per minute or more during Holter monitoring. How to cover the arrhythmic risk in post-myocardial infarction patients before they qualify for guideline recommended ICD therapy? An option is to bridge with a wearable defibrillator cardioverter or WCD. West investigators randomly assigned 2,302 patients with acute myocardial infarction and ejection fraction 35% or less in a 2:1 ratio to receive WCD plus guideline directed therapy or to guideline directed therapy only. WCD did not significantly lower the primary outcome of arrhythmic death than control, but a major problem regarding WCD is the compliance. Of the 48 participants in the device group who died, only 12 were wearing the device at the time of death. Here are the first set of relevant journal references. Second set of references are here. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.